Hello, everyone. Welcome to the Green Top Guidelines summary of the day. Let's see the salient points of the Green Top Guideline Epilepsy in Pregnancy, published in year 2016. We are going to have the Green Top Guideline 68 per day. Epilepsy is one of the most common neurological conditions in pregnancy with a prevalence of 0.5 to 1%. I repeat, 0.5 to 1%. This is the exam question. This guideline summarizes the evidence on maternal and fetal outcomes in women with epilepsy. An estimated 2,500 infants are born to women with epilepsy every year in United Kingdom. About 1/3 of women with epilepsy are in the reproductive age group. The risk of the major congenital malformation in the fetus is increased in women with epilepsy taking anti-epileptic drugs, an important exam question. The diagnosis of epilepsy and epileptiform seizures should be made by a medical practitioner with expertise in epilepsy, usually a neurologist. Women with a history of epilepsy who are not considered to have a high risk of unprovoked seizures can be managed as low-risk women in pregnancy. This is important to classify the seizure type and epilepsy syndrome. Women with epilepsy, their families, and healthcare professionals should be aware of the different types of epilepsy and their presentation to assess the specific risks to the mother and the baby. What is the clinical presentation of various seizure types and their effects on the mother and the baby? Please have a look on table 1 of the Green Top Guideline, the tonic-clonic seizures, the absent seizures, juvenile myoclonic epilepsy, and the focal seizures. What is the differential diagnosis? In pregnant women presenting with seizures in the second half of the pregnancy, which cannot be clearly attributed to epilepsy, immediate treatment should follow existing protocols for eclampsia management until a definitive diagnosis is made by a full neurological assessment. Other cardiac, metabolic, and intracranial conditions should be considered in the differential diagnosis. Neuropsychiatric conditions, including non-epileptic attack disorders, should also be considered. Women with epilepsy who are planning their pregnancy should have a clinician competent in the management of epilepsy take the responsibility for sharing decisions around choice and dose of anti-epileptic drugs based on the risk to the fetus and control of seizures. Women with epilepsy should be reassured that most mothers have normal, healthy babies and the risk of congenital malformations is low if they are not exposed to anti-epileptic drugs in the periconception period. Women should be informed that the risk of congenital abnormalities in the fetus is dependent on the type, the number, and the dose of anti-epileptic drugs. The women with epilepsy and their partners need to be informed about the possible adverse impact on long-term neurodevelopment of the newborn following in utero exposure to sodium valproate. Based on limited evidence, in utero exposure to carbamazepine and lamotrigine does not appear to adversely affect the neurodevelopment of the offspring. There is very little evidence of levetiracetam and phenytoin. Parents should be informed that evidence on long-term outcomes is based on small number of children. All women with epilepsy should be advised to take 5 milligrams of folic acid per day prior to the conception and to continue the intake until at least the end of the first trimester to reduce the incidence of major congenital malformation. Pre-pregnancy folic acid 5 milligrams per day may be helpful in reducing the risk of the anti-epileptic drugs related to cognitive deficits. The lowest effective dose of the most appropriate anti-epileptic drugs should be used. Exposure to sodium valproate and other anti-epileptic drugs polytherapy should be minimized by changing the medication prior to conception as recommended by an epilepsy specialist after a careful evaluation of the potential risks and the benefits. Therefore, women with epilepsy should be provided with verbal and written information on prenatal screening and its implications, the risks of the self-discontinuation of anti-epileptic drugs, and the effects of seizures and anti-epileptic drugs on the fetus and on the pregnancy, breastfeeding, and contraception. Women with epilepsy should be informed that the introduction of a few safety precautions may significantly reduce the risk of the accidents and minimize anxiety. Healthcare professionals should acknowledge the concerns of women with epilepsy and be aware of the effect of such concerns on their adherence to the anti-epileptic drugs. The antenatal care. Pregnant women with epilepsy should have access to a regular, planned antenatal care with a designated epilepsy care team. Women with epilepsy taking anti-epileptic drugs who become unexpectedly pregnant should be able to discuss the therapy with an epilepsy specialist on an urgent basis. It is never recommended to stop or change anti-epileptic drugs abruptly without an informed discussion. All pregnant women with epilepsy should be provided with information about the UK Epilepsy and Pregnancy Register and invited to register, a very important patient safety point for MRCOT Part 3 OSCE station. When do we screen for detection of the fetal abnormalities? Early pregnancy can be an opportunity to screen for the structural abnormalities. The fetal anomaly scan at 18 to 20 plus 6 weeks of gestation can identify the major cardiac defects in addition to the neural tube defects. All women with epilepsy should be offered a detailed ultrasound in line with the National Health Service Fetal Anomaly Screening Program standards. Based on the current evidence, routine monitoring of serum anti-epileptic drug levels in pregnancy is not recommended, although individual circumstances may be taken into account. Healthcare professionals should be alert to signs of depression, anxiety, and any neuropsychiatric symptoms in mothers exposed to anti-epileptic drugs. In the antenatal period, women with epilepsy should be regularly assessed for the following, that is, risk factors for seizures, such as sleep deprivation, stress, adherence to anti-epileptic drugs, seizure type and frequency. If admission is required, antenatally, women with epilepsy at reasonable risk of seizures should be accommodated in an environment that allows for continuous observation by a carer, partner, or the nursing staff. Healthcare professionals need to be aware of the small but significant increase in obstetric risks to women with epilepsy and those exposed to anti-epileptic drugs, and to incorporate this in the counseling of women and the planning of the management. Serial growth scans are required for detection of small for gestational age babies and to plan further management in women with epilepsy exposed to anti-epileptic drugs. There is no role for routine antepartum fetal surveillance with cardiotocography in women with epilepsy taking anti-epileptic drugs. What is the role of vitamin K in preventing hemorrhagic disease of the newborn and maternal hemorrhage in patients of epilepsy? All babies born to women with epilepsy taking enzyme-inducing anti-epileptic drugs should be offered 1 milligram of intramuscular vitamin K to prevent the hemorrhagic disease of the newborn. However, we have insufficient evidence to recommend the routine maternal use of oral vitamin K to prevent the hemorrhagic disease of the newborn in women with epilepsy taking enzyme-inducing anti-epileptic drugs. There is insufficient evidence to recommend giving vitamin K to women with epilepsy to prevent the postpartum hemorrhage as well. A very important extended match question and the single best answer. Women with epilepsy should be reassured that most will have an uncomplicated labor and delivery. The diagnosis of epilepsy per se is not an indication for planned cesarean section or induction of labor. In women with epilepsy taking enzyme-inducing drugs who are at risk of preterm delivery, doubling of the antenatal corticosteroid dose for prophylaxis against the respiratory distress syndrome in the newborn is not recommended. I repeat, is not recommended. How about the intrapartum care? Pregnant women with epilepsy should be counseled that the risk of the seizures in labor is low. However, the adequate analgesia and appropriate care in labor should be provided to minimize the risk factors for seizures such as insomnia, stress, and dehydration. Long-acting benzodiazepines such as clobazam can be considered if there is very high risk of seizures in the peripartum period. Again, this is an exam question repeated multiple times. Anti-epileptic drugs intake should be continued during labor. If this cannot be tolerated orally, a parenteral alternative should be administered. Early obstetric unit should have written guidelines. Now, all these obstetric units should have written guidelines on the management of seizures in labor. Seizures in labor should be terminated as soon as possible to avoid the maternal and fetal hypoxia and fetal acidosis. The benzodiazepines are the drugs of choice. The continuous fetal monitoring is recommended in women at high risk of seizure in labor and following an intrapartum seizure. What is the recommended method of analgesia in labor? We get this question in exam. I need your attention because the pain relief in labor should be prioritized in women with epilepsy with options including transcutaneous electrical nerve stimulation, the TENS, nitrous oxide and oxygen, that is Antonox, and the regional analgesia. The most important point which you have to notice for the exam purpose is pethidine should be used with caution. Therefore, we are not going to select an exam as an answer for the single best question. Diamorphine should be used in preference to pethidine. Effects of the induction of labor. We don't have any known contraindication to use if any induction agent is being used in women with epilepsy taking anti-epileptic drugs. For women with epilepsy friends at risk of peripartum seizures, delivery should be in the consultant-led unit with the facilities for one-to-one midwifery care and the maternal and neonatal resuscitation. The decision to use water for analgesia and birth should be made on an individual basis. Women with epilepsy who are not taking anti-epileptic drugs and who have been seizure-free for the significant period may be offered a water birth after discussion with their epilepsy specialist. Women with epilepsy and their caregivers need to be aware that although the overall chance of seizures during and immediately after delivery is low, it is relatively higher than during pregnancy. Women with epilepsy should be advised to continue their anti-epileptic drugs postnatally. Mothers should be well supported in the postnatal period to ensure that triggers of the seizure deterioration, such as sleep deprivation, stress, and pain, are minimized. If the anti-epileptic drugs dose was increased in pregnancy, it should be reviewed within 10 days of delivery to avoid the postpartum toxicity. The neonates born to women with epilepsy taking anti-epileptic drugs should be monitored for adverse effects associated with anti-epileptic drugs exposure in utero. Women with epilepsy who are taking anti-epileptic drugs in pregnancy should be encouraged to breastfeed. Based on the current evidence, mothers should be informed that the risk of adverse cognitive outcomes is not increased in children exposed to anti-epileptic drugs through the breast milk. Postpartum safety advice and strategies should be part of the antenatal and postnatal discussions with the mother alongside breastfeeding, seizure deterioration, and anti-epileptic drugs intake. Postnatal mothers with epilepsy at reasonable risk of seizures should be accommodated in single rooms only when there is provision of continuous observation by a carer, partner, or nursing staff. Women with epilepsy should be screened for depression, and the puerperium is the high-risk time. The mother should be informed about the symptoms and provided with contact details for any assistance. Women with epilepsy should be offered effective contraception to avoid the unplanned pregnancy. The copper intrauterine device, the levonorgestrel intrauterine system, and the medroxyprogesterone acetate injections should be promoted as reliable methods of contraception that are not affected by enzyme inducers, a confirmed question you're being tested for in your exam. They always give the enzyme inducing drugs, and you have to pick up the best contraception for the patient. Women taking enzyme inducers like carbamazepine, phenytoin, phenobarbital, primidone, oxcarbazepine, topiramate, and aceclidine. All these are very important medications, should be counseled about the risk of failure when some hormonal contraceptives are being used. Women should be counseled that the efficacy of oral contraceptives, the combined hormonal contraceptions, the progesterone-only pills, the transdermal patches, the vaginal ring, and the progesterone-only implants may be affected if they are taking the enzyme-inducing drugs. That is, carbamazepine, phenytoin, phenobarbital, primidone, all are important. All methods of contraception can be offered to women taking non-enzyme-inducing drugs like sodium valproate, an important MRCOG3 station, levetiracetam, gabapentin, vigabatrin, tegabine, and pregabalin. All are non-enzyme inducers. Please make a list. Women with epilepsy taking enzyme inducers should be informed that a copper intrauterine device is the preferred choice for emergency contraception. Emergency contraception pills with levonorgestrel and uliprazole acetate are affected by enzyme-inducing drugs. Women taking lamotrigine monotherapy and estrogen-containing contraceptives should be informed of the potential increase in seizures due to a fall in the levels of lamotrigine. You will find this question in all exams, undoubtedly a very important exam question regarding the fall of the lamotrigine levels with combined oral contraceptive pills. Moreover, I would like you to go to my live discussion session because there I've made a table, the list of the drugs and how the exam questions they actually come. The risks of the contraceptive failure and the short and long-term adverse effects of each contraceptive method should be carefully explained to the women. Effective contraception is extremely important with regard to stabilization of epilepsy and planning of pregnancy to optimize the outcomes. Women with epilepsy should be informed of the effect of changing the dose of anti-epileptic drugs and seizures and its impact on the driving privileges. Healthcare providers need to be aware of equality legislations in UK that protects individuals with a disability from discrimination. The must points to learn from the Green Top guidelines are a question regarding the drug safety in the pregnancy and the antenatal care, which one to prescribe. The contraception is a must-coming question in exam with an enzyme inducers and non-enzyme inducers. The antenatal care, the interpartum care, and the postpartum care, important points both for the single best answers in the extended match questions, and not to forget as an OSCE station of the epilepsy patient. Don't forget the list which I've given you for the folic acid 5 milligram. Epilepsy is one of the most important medical disorder where the folic acid in the pregnancy is going to be the high dose 5 milligram. Best of luck from the entire team of RFA tutors, wishing you all success and happiness. See you all with the next guideline summary. Until we meet again, take very good care of yourself. Bye-bye.